My name is Isatu Kanu James. It is my pleasure to introduce to you Dr. Icilma V. Fergus. Dr. Fergus Rowe is an associate professor of medicine and director of cardiovascular disparities at the Icahn School of Medicine at Mount Sinai. She is the director of hypertension and lipidology and cardiology at Mount Sinai. Her undergraduate education was at Barnard College, Columbia University, and her medical studies were at SUNY Downstate. She completed her residency and chief residency at Albert Einstein Medical Center. Dr. Fergus completed her cardiology fellowship at Weill Cornell Medical Center. She is board certified in internal medicine and cardiology. She focuses on areas related to preventive cardiology, including lipids and hypertension, women's heart disease, and cardiovascular health advocacy. Dr. Fergus is the founder and director of a series of healthy heart projects. These programs focus on addressing lifestyle motivation for cardiac prevention, as well as education, demonstration, and screening to promote optimal health management of cardiovascular risk factors and chronic conditions that may lead to heart disease. Again, it's my pleasure to introduce Dr. Fergus.
Good afternoon and welcome, everyone. Today is just such an important day. You've already heard from the other presenters how important it is to talk about heart disease. It's Heart Month, it's Black History Month. And in Dr. Allison Munch's presentation, she talked about equity or lack thereof, disparities. Because as you know, Black and Brown communities, we continue to be the ones likely to die earlier from preventable diseases. And so I will hope to show you in my presentation exactly sort of what is the state of us as Black people around the globe in terms of our life expectancy. I'll talk a little bit about the mental or emotional components that lead to or can contribute to heart disease, and then tell you a little bit about what a heart attack looks like. Very briefly mention sudden cardiac death, because I know that one of our speakers will talk about her personal story about heart disease and sudden cardiac death. And we will also hear about aging, because, we talk about Black don't crack, right? And how beautiful we look on the exterior. And you all look so beautiful out there, but what's going on inside? So it's great to look wonderful on the outside. And what about what's going on inside? So I'm truly grateful to be here today. I'm co-chair with Isatu for ITS, and I'm a proud member of the HHS committee. So without further ado, let me go ahead and proceed with my presentation. So I'm going to be talking about mental health, aging, and the heart. So it's a little tough for me to see from here. However, the first slide shows the life expectancy in the entire globe. And it's hard to see, but what you can see as you go up this line is the longer life expectancy. And the shorter life expectancies are the countries down here. And if you look, those are the dark countries like Nigeria, like all the countries in Africa, the Caribbean, they have a shorter life expectancy, somewhere around the average age of 65. Right? Whereas some of the European countries, the life expectancy is a lot longer, in the 70s. Now, this is a slide that shows the life expectancy here in the United States. And these bar graphs actually represent the average life expectancy for whites, Blacks, and Hispanics. This last bar graph represents Blacks. And as you could see, the life expectancy on average is about 75. But when you look at Hispanics and white, their life expectancy is longer. This schematic on the right also shows the same thing. The bar graph indicates that over time, life expectancy has improved among all the groups. But you could see that the Black individuals are likely to have a less life expectancy, a lower life expectancy, and it hasn't changed. We still lag behind. So do you know that the average life expectancy here in the US for a Black male is about 10 years behind that of a white female. The average life expectancy of a Black female is about 5 years less than a white female. In this country, that shouldn't happen. But in this talk, I'm not talking about disparities. I just simply wanted to point that out. And this is also life expectancy in the Caribbean. So you could take a look at the different countries and you'll see that the life expectancy for male and female is still lower than the life expectancy for white females and Hispanic females in this country. And some of the countries in the Caribbean are even more likely to have that, such as Haiti, Jamaica, and some of those other countries, the life expectancy is a lot lower. Okay, so the one thing that I do want to point out, because a lot of people think that, oh, I'm young, I'm not going to have a heart problem. But guess what? It can affect you at any age. So across the bottom is the age of the lifespan, and the bar indicates the percentage of people who are likely to have heart disease at that age. You can see men in red and women in white. Now, a lot of you women say, well, I'm menstruating, and I know the OB/GYNs will probably differ with me. However, the menstrual cycle protects you to a point. You can have heart disease in the 20s, 30s, 40s, and 50s. Yes, it does increase as you go older, get older. And in some cases, as you get older, as seen in the white, you surpass men. So once you no longer have that protective mechanism, it's even more likely for these women to have heart disease. So it's a myth that you cannot have heart disease when you're young. So be prepared. So the next slide, I want you to ask yourself, do you have a young heart or do you have an old heart, right? The one on the left, on my right, your left, is a young, healthy heart. You feel young, you exercise, you take care of yourself, you do your risk factors, but guess what? You can look really good on the outside, as I talked about, and your heart could look like this heart on the right that is just very tired looking and sick looking, and that's what's going on inside. Well, I hope all of us in this room has this young, healthy heart. So how do you do that? Well, these are the risk factors for heart disease, and some of them we can't help, right? We can't help who's our family, right? Because some people may have heart disease that runs in the family and it's genetic. We can't help if we're male or female, and we can't help our age. Once we're older, but there's some that we can fix, right? We can watch what we eat, we can get exercise, we can not smoke or vape, we can watch our blood sugar or diabetes, we can watch our cholesterol, okay, and our blood pressures. So know your numbers. And women have a particular risk factor, but now we know maybe more important. And so that's inflammatory issues, and of course, the mental health, okay? So that's very important, mental health and stress. And this just shows it's not that diabetes and cholesterol runs in your family, it's that no one runs in your family. So make sure people are exercising. So let's talk a little bit about mental health and the heart, and I'm gonna move a little faster because I know our next speakers are coming up. But it's very important to recognize that your mental state affects your heart. So we're talking about stress, anxiety, anger, and depression. And yes, they affect your heart. So in the next slide, much research has been done that links depression to the heart. With depression, you can see people having more strokes, your blood pressure is elevated, and actually after you've had one of those conditions, you're more likely to have depression. So it's very significantly linked to the heart. And even this was a study that looked at over 3,000 to 4,000 women. And even if you didn't have heart disease to begin with, if you're depressed, then you can have, heart disease. So just be aware of that. Depression means a constant state of being sad and not enjoying anything, not going out. Everybody gets sad on a daily basis, but overall, you don't want to be depressed, or if you do, get some help because it can help you to avoid having issues with your heart. And anxiety is also a risk for heart disease. People present with anxiety attacks. That's just like chest pain, heart pain, palpitations. In fact, I had one patient who presented with a panic attack, but it really was her heart. Her heart was 30 beats per minute. And when we did the EKG, we were surprised. We sent her to the cath lab. She ended up not only needing a pacemaker, but she had blockages. So anxiety, heart disease can present as anxiety, but also anxiety could be, leading to heart problems because of increased heart rate, et cetera. Same thing with anger. Anger increases your blood pressure and your heart rate. So again, anger is another mechanism of your heart that can cause heart disease. So make sure to find ways to disseminate your symptoms, your feelings, I should say. If you're angry, talk it out, relax, exercise, drink water, do whatever you can to mitigate it, because if your blood pressure and heart rate goes up, those cortisol hormones and dopamines, they go up, they cause problems. So that's something to watch out for. And of course, stress. So that's a constant state of a lot of these other conditions that just stays with you. And a lot of us, we say we're stressed out all the time, but of course, it's an independent risk factor for high blood pressure, which is maybe why a lot of us have high blood pressure. So let's just quickly look at that. And I just wanted to share this, especially you women who are married in here. Let me tell you, men benefit from marriage, no matter if it's happy or not. But women, and this is a true study, it was done in the Stockholm study, if women are in an unhealthy, unhappy relationship, it increases their risk for heart disease. Okay, being single does not independently increase your risk for heart disease. So I don't have enough time to talk about it, but on the bottom right, it shows broken heart syndrome. So we're gonna just move ahead. I'm gonna skip through these pictures. This last one, you're gonna hear from Melinda Murray, because she's gonna talk about her story. But this talks about sudden cardiac death, which we see in the Black community quite a bit. And it affects 1 in 9 men, and they're most likely to die from heart disease. So we have to find ways of mitigating that, and she's gonna share that with us. But you know what? After this conference, hopefully we'll figure out what we can do if we see someone pass out and we can save their lives. So with that, I'm just gonna show a quick video of what your normal heart should look like. So we could go to the video now.
The heart pumps blood throughout the body, carrying oxygen and nutrients to every cell. It's this circulation of blood that is vital to sustaining life. The heart is an organ made up of several tough layers of muscle. The pericardium is the thin layer that covers the exterior, while the endocardium lines the inside walls. The heart is divided into 4 chambers, 2 upper and 2 lower. The upper chambers, known as the atrium, receive blood coming into the heart. The lower chambers are the ventricles that pump blood out. Between each chamber are valves that open and close and help keep the blood moving. They are the tricuspid, mitral, pulmonary, and aortic valves. A pumping cycle starts when oxygen-depleted blood returns to the heart after circulating throughout the body. The blood enters through the right atrium before flowing to the right ventricle. It's then pumped to the lungs via the pulmonary arteries. There, blood is rejuvenated by air that's breathed in. The oxygen-rich blood returns to the heart through the left atrium, where it goes to the left ventricle. Then, by way of the aorta artery, the fresh blood is pumped throughout the body before the process repeats itself. That process happens with every heartbeat, and it's relentless. The heart beats 100,000 times a day, 40 million times a year, and up to 3 billion times over an average lifespan. But there are conditions that can disrupt a heartbeat and that normality. They can range from myocardial infarction or a heart attack to heart disease and hypertension. In contrast, exercise and emotional excitement can also have an impact on a person's heartbeat. The various blood vessels that comprise the circulatory system are a network of veins, arteries, and capillaries that span over 60,000 miles throughout the body, and the heart is the pump at the center of it.
We want to just say thank you to, we call her Dr. Icy, for that incredibly informative presentation on the heart. And if you have any questions, please definitely grab her and ask your questions. And I hope everyone's heart is the happy young heart and not the heart that looks old. I am Denise Williams, a proud member of the Greater Hudson Valley chapter of the Links Incorporated. Good afternoon personally, in person and virtually. It is my pleasure to introduce our next speaker, Dr. Brigette Holder. Dr. Holder is both an internist and a dermatologist. After receiving her medical degree from Downstate Medical School, she went on to pursue her internal medicine training at Brown University Miriam Hospital in Providence, Rhode Island. During the residency, she did a tropical medicine elective in Uganda, Africa, a step which was instrumental in her decision to pursue a career in dermatology. After completing a postdoctoral fellowship in the therapeutics of psoriasis at Rockefeller University, Dr. Holder went on to complete her residency in dermatology at SUNY Health Science Center of Brooklyn Downstate Medical Center in 2004. Early in practicing her career, Dr. Holder had the urgency to give back to her Brooklyn community, working for various community dermatology clinics and hospitals while simultaneously building her private practice, the Park Slope Dermatology and Medi-Spa, where she currently practices as a solo practitioner for over 15 years while focusing on cosmetic dermatology. It is our pleasure to welcome her, Dr. Holder, to the stage.
It's my pleasure to be a speaker here today and to address all of you on aging and skin of color and how I, as a woman of color, can decrease the perceptions of skin of color being looked at as different in the sense that cosmetically, dramatic changes cannot be made. Just a little bit of a personal story. When I trained at Downstate, which was a great place to train, I did my residency in dermatology there and completed it in 2004. I noticed that we were taught the foundations of dermatology and about skin, and we were taught about skin of color, but in terms of therapy, there was almost an apprehension in terms of darker toned skins. There was just like a lack of knowledge of how we could actually make dramatic changes in conditions and have a happy group of people who look like me. So I felt that I needed a little bit more insight. So I decided after graduating in 2004 to go to Jamaica and shadow a dermatologist there, Dr. Pat Dunwell. And what I learned from her was amazing in terms of changing my perception. Dr. Dunwell at the time was a cosmetic dermatologist and cosmetic surgeon, and introduced me to modalities which I never realized could be done on skin of color. So what is skin of color? This talk is going to be a brief overview. I'll expound more on the anatomy and epidemiology and therapeutics of the skin. I just want to show you in this brief synopsis what we've done in Brooklyn, which was so important for me to actually practice in Brooklyn, return to my community and make a difference. I'm just going to basically show you the conditions that I treat and the therapy that I initiate at Park Slope Dermatology. And I think that you'll see that it's, you can, if you do have, conditions that you were told that cannot be at all affected, that's not true, they can. So in dermatology, we classify skin types into 6 Fitzpatrick phenotypes, type 1, 2, 3, 4, 5, and 6. Skin of color comprises 4 through 6. This would be a type 1 based on how this patient responds to the sun. This patient here would be a type 2 based on Fitzpatrick phenotype. Type 3, I don't have a good picture of, but 4, this Asian patient here, 5, this Indian patient here. So as you can see, it not the classification based on race is not necessarily how we view skin type in dermatology. Someone could be a type 5, brown skin African American, and be this. We treat that person the same as we would someone from South Asia. So this is a type 5 patient, and these 2 patients that look like me are type 6. These are the type of skin. These 3 skin types comprise skin of color, and this is what I wondered why we didn't do anything, in terms of treating these patients, in terms of skin aging and modifying the way they presented to us, at downstate. This is my goal in life was to change the perception of therapeutics, which is what I worked on at Rockefeller in my fellowship. So in terms of the aging process, what happens in the aging process? Here's a great diagram. As we age, the nice contour, sharp contour that's seen here, actually, we lose it due to gravity, due to collagen shifts and elastin shifts, bone density shifts, the sebaceous gland, which I'll expound on more upstairs. We basically develop jowls, as in this diagram here. So the way I'm gonna briefly talk about what I do at downstate is just show you conditions that I've seen and the therapies that we have initiated there, and the life-changing dramatic results that we've gotten. This patient here, as you can see, double chin or submental fat pad. The pathology lies here in the subcutaneous fat. So we did 3 cool sculpting treatments, which is a device, and you can see that we got back her nice contour. As we age again, due to a loss of elastin and collagen, the neck, because of the reshifting of the collagen and elastin, we lose the tightness and we get horizontal lines. So here we did a procedure called Fraxel. This patient did 3 Fraxels. And as you can see, her neck and the seconds, these are the results that we got at Park Slope Dermatology. A nice tight neck, which again is what happens when we age. We lose the tightness and we get these lines, the lines completely gone. Fraxel. I get patients of color coming all the time that say to me, I never knew that we could do the Fraxel. I went to other dermatologists and they said, because of your skin type, cannot be done. And the only reason why I came to you is because I saw on your before and after pictures, which is a way I feel that I'm changing the perception, is in my before and after pictures. I'm showing people that yes, you can have these modalities that will help you to age gracefully. So this patient here, as you can see again, because of the shifts that occur with collagen and elastin and the neuromuscular junction, communication between the nerve and the muscle ending through a space called the synapse. Botox basically prevents that communication. So therefore, the contractions go away for a certain time span, which is individualized, 3 months, 6 months, a year. But look at him. He came to me and he says, Doc, my daughter's graduating. She's a valedictorian. Do something. I have to look young. So the furrows, gone. Yes, skin of color can have Botox. And yes, you never see on sites before and after pictures with Botox and skin of color. So my patients, I get consent from them, and I tell them, help me change the perception. And they say, of course, gladly I give you consent. Not all, but most. This is a Japanese woman, type 5, because of the tone of her skin. So here we did Botox in her glabella area. Sorry. The glabella area here in between the brows and those, she said, oh, the job that I do, I'm turning people away. This is dangerous for me. Do something. So I said, yes, we can. And we did. We injected her with Botox, and here you see, the furrow is gone. So it seems maybe a little superficial, but it's not. It's deep, and it's very important in dermatology for people to know that type 4 through 6 can have the same procedures and get results, since they were told that that wasn't possible by many. Next, I'm gonna go as fast as I can. But I just want to show you the dramatic results that I've seen. This patient here, I see this a lot, maturational dyschromia in the aging process, where we get redistribution of pigment at the dermo-epidermal junction. This is where the pigment is laid down. At this junction, we make melanin, and as we age, the melanocytes, due to the extrinsic causes of aging, sun exposure, we make a little bit more, the melanocytes just lay down a little bit more melanin. So she came to me with this chromia, generalized hyperpigmentation, increased pigmentation after one Fraxel. Again, she was told that you can't do Fraxel on your skin type, just like I was told as a resident that you can't do lasers. And I said, and I'm supposed to be the expert one day? Got to change that perception. So this patient is actually mine and Dr. Fergus's contemporary. We all went to medical school together. I hope I'm not revealing anything, but when he turned 50, he said to me, do something. I want your birthday gift to me should be to make me look like a 30-year-old man again. And we did. Here we go. So this is the before. He has maturational dyschromia, and this from the side view. Can you see the difference? And I made one of my best friends in the world happy.
Thank you, Dr. Holder.
My pleasure.
Okay. It is my pleasure to introduce to you Mrs. Melinda Murray Nyack, founder and president of Dominic A. Murray 21 Memorial Foundation. Mrs. Murray Nyack is the founder and president of the Dominic A. Murray 21 Memorial Foundation, Dom Heart 21. Dom Heart 21 was established in 2010 after the tragic death of 17-year-old Dominic Murray. Dominic was stricken by sudden cardiac arrest while playing basketball at school. Those who witnessed Dominic's collapse did not recognize that he was in cardiac distress, which delayed CPR, and an AED wasn't used until EMS arrived. By then, unfortunately, it was too late. It wasn't until Dominic's autopsy that his congenital heart condition was revealed. Just 3 years prior to Dominic's sudden death, his father had a fatal heart attack, and at the age of 42. Suddenly a widow and a parent who lost her only child, Melinda devoted her life mission to championing life-saving outreach. Dom Heart 21 is committed to preventing sudden cardiac arrest and death in young people. The foundation provides heart screenings for early detection of risk factors and conditions related to sudden cardiac arrest, places automated external defibrillators where youth live, learn, and play, and facilitates CPR and AED trainings. Please welcome Mrs. Melinda Murray Nyack to the stage.
And I got a phone call, and when I looked at my ringer, it listed Dom, my baby boy. And when I picked up the phone, I said, "Hi Dom, what's up?" and it wasn't Dominic on the other end.
The boys basketball team and the girls basketball team, it was preseason, were scrimmaging. The girls team at a certain point stopped because we noticed that Dominic was on the floor, had collapsed. We were all just so scared. That's when I saw somebody did come in with an AED machine.
As I was rushing out to go to the school, I got another phone call saying that they had transported him to the hospital. And by then already 20 minutes had passed by, but no one was telling me that Dominic had regained consciousness.
We got to the hospital and we asked the front, we said, what's going on? And I look through the window and I see the coach and one of his teammates, because they were the only people that were allowed back there. And I just see them fall crying to the floor, and I just knew that everything wasn't okay.
The parents should make sure that the pediatricians are doing a thorough cardiac exam, a thorough history and physical, and there should be a special consideration and focus on past medical history and family history of sudden cardiac death. If anything does show up in the primary care office, the parents should immediately reach out to a pediatric cardiologist for clarification and complete diagnosis. Everybody should know how to do CPR. It's the easiest thing in the world to learn how to do. If the diagnosis is known, CPR gets started right away. If the diagnosis is unknown, CPR gets started right away.
Good afternoon, everyone. It's such an honor to be here with you today. And every time I look at that video, I get to see my son, number 21, who is playing in the game. And it just brings back such good feelings because I see him full of life. A child that was seemingly healthy, that before he collapsed on October 5th, 2009, I had no clue that there was something going on wrong inside of his heart. So I just wanted to get a little bit more personal to let you know that I was no stranger to heart disease before my son collapsed on that fateful day. Cardiac arrest first struck my family in 1998 when my mother died from a heart attack at the age of 57. Her heart stopped in her sleep, but we recognized those signs because she had multiple heart attacks, but she was able to live through age 57. In 2006, that's when my first husband passed away suddenly at the age of 42. His heart stopped on his way home from the airport. And then just 3 years later, after that, our only child collapsed on the basketball court at Farmingdale State College in the middle of a routine layup. When Dominic collapsed, those around him did not witness that he was in cardiac distress. And why would they? He was young, vibrant, energetic, and he could play more than one game in a day. So no one started CPR right away, and they ran right past the AED that was right outside of the gym door. And the real tragedy is, it wasn't until his autopsy that his congenital heart condition was revealed. Dominic was born with a structural abnormality and mitral myxoid valve. So there were two things that were going on wrong that was never picked up in pre-participation sports physicals, and he was diagnosed healthy at every well-child visit. We found out that had Dominic been screened with an EKG, had someone started CPR right away, and had someone used that life-saving AED, he would probably still be here today. And through Dominic's foundation, we've implemented those things that he did not have in his favor. To date, we have screened over 6,000 student athletes for underlying heart conditions, and 104 lives have been saved since 2011. We've trained over 26,000 people in CPR and how to use an AED, and 4 lives have been saved. And we placed 41 AEDs. We do work domestically in the United States, as well as in Grenada, where my son's roots stem from. where we are also helping to place AEDs in Grenada and provide training. Over 356,000 people die are impacted by cardiac arrest in the United States every year. 23,000 of those that are affected are young people under the age of 18 that die every year. What parents don't know, that sudden cardiac arrest is the #1 killer of student athletes in the United States. In October 2021, we passed Dominic's Law in New York State, which would require that parents get information on sudden cardiac arrest, signs, symptoms, and risks and preventions. And also coaches are trained differently and teaching staff. So children who are at risk, children who are pending at risk, parents have this information, they know how to help these children. And there are some people that do not even have an underlying heart condition that manifests until then. So by having this information, by Dominic's Law finally passing after 10 years, this information is brought back to parents. 1 in 25 schools will have a sudden cardiac arrest on their campus every year. It just doesn't affect athletes though. It's non-competitive athletes as well. What can be done about it? Sudden cardiac arrest and death in young athletes is, and all youth are preventable through heart screenings, primary prevention, which is heart screenings that include an EKG and an echocardiogram if needed to identify these underlying heart conditions. So that's primary prevention. And when you think about secondary prevention, knowing CPR, cardiopulmonary resuscitation, hands-only CPR, compression only, and how to use an AED is critical. Ensuring that schools have a cardiac emergency action plan so that if a sudden cardiac arrest should occur, immediate action can take place and that child can be saved. It's important that AEDs are placed wherever children live, learn, and play, because you do need access to those life-saving devices. Education is key. Recognizing, all right, now I'm clicker, okay. Now, recognizing and responding to sudden cardiac arrest is critical. And I have 1 minute, and this is what I want to leave with you for that 1 minute. Our mantra at Dom Heart 21 is call, push, shock. Calling 911, pushing hard and deep in the center of the chest, and using the AED when it arrives. We want call, push, shock to be as common as stop, drop, and roll. You should know this. You should be empowered by this. We're going to be doing trainings in the workshop because anyone can learn how to save a life. Kids don't have to die. And for the parents and guardians and grandparents and all, I want to leave you with this. If you could prevent the tragedy of losing a child to sudden cardiac arrest, why aren't we? Thank you.
Let's give another round of applause to Melinda, Murray, and Nyack, who's really making a difference in our children's lives. I have the pleasure of, as we're getting our panelists on the stage, I have the pleasure of introducing two dynamic doctor duos from the Greater Hudson Valley chapter. They will be our moderators, and I'd like to start with Dr. Paige Long-Sharps, who was born and raised in Brooklyn, New York. Upon completion of high school, Paige entered Howard University in Washington, D.C. Dr. Sharps completed her OBGYN residency program at Columbia University. For 15 years, she was the medical director for the Grand Concourse Division of Montefiore's Medical Center. She is also an adjunct associate clinical professor at Pace University in the Physician Assistant Program. Dr. Long-Sharps also developed and patented a medical device, the Patnus adapter. Currently, Dr. Long-Sharps is a regional medical director of the National Inpatient Care Management Eastern Region for United Health Group. Next, I would like to also introduce our second moderator, which is Dr. Monica Foreman Hudson. She is a board-certified obstetrician and gynecologist at Montefiore Medical Center. Dr. Hudson received her Bachelor of Science degree in psychobiology from Yale University. She received her doctorate in medicine from the Mount Sinai School of Medicine. Currently, she too is an assistant professor of obstetrics, gynecology, and women's health at the Albert Einstein College of Medicine and is currently the medical director of the Scarsdale Women's Center. She was recently inducted into the Davidoff Society for Excellence in Medical Student Education. Dr. Foreman Hudson has been practicing for 25 years, and she sees patients in Scarsdale, New York, and the Bronx. Let's bring up these dynamic doctor duos to moderate what will be an exciting session.
Good afternoon. Can we give a hand again to our presenters? They were all excellent, very informative. So we're going to start with a couple of questions of our own, but we also have mics in the audience. So anyone feel free to come in the aisles if you have a question, and our panelists will answer. So I'm going to start with Dr. Fergus. A question for you. Why do Hispanics have longer life expectancies than Blacks despite the preponderance of cardiac, metabolic, and socioeconomic risk factors?
Thank you for that question. So I did explain that Blacks have a lower life expectancy, and for many reasons, we know that this is a disparity because there's so many reasons. So one of the main things is, actually Rosalind started Black Health Matters based on that. So what happens is that in many of our Black and Brown communities, there's lack of access to care. The cost of medications is very high. Then you also have a patient, doctor, or healthcare system distrust. Some people talk about the Tuskegee experiment that happened with Black men, but sometimes there is a distrust of the medical community. People think that maybe they're giving them medications that they shouldn't be taking or that may cause a problem. You also have non-adherence. So this is like particular to some of us as Black women. We talk about some of the blood pressure medications may take our hair out, and they may not take those medications based on that. And sometimes the men talk about whether it affects their masculinity. But a lot of times too, something has to do with not necessarily understanding there's health literacy. So having programs like this that allows you to understand and learn about what, how good health means is paramount. So with all of that in mind, and then taking good care of yourself with the risk factors that I talked about, diet, managing your blood sugar, your blood pressure, your cholesterol, getting enough exercise, 30 minutes most days of the week, which I know you guys are doing, and the other risk factors, all of that will help to improve our life expectancy.
Thank you. The next question is for Dr. Holder. Is it more genetics or certain skincare products that play the most important role in the aging process?
Sure, genetics is a factor and often cannot be modified, but there are extrinsic, factors that contribute to the aging process. In terms of what I propose to my patients is a regimen, a skincare regimen, and I can't say how important it is to moisturize. So moisturizing is the key, and starting as early as possible. I often tell my moms to bring their kids in for a visit, just to educate them on products, cosmetics, just over-the-counter products. A gentle skin cleanser is very important. A lot of times we're using cleansers that are irritating our skin and causing contact dermatitis. And that can be one of the reasons why we get this maturational dyschromia as we age, the hyperpigmentation. Also, the most important factor, I think, as a dermatologist, especially a woman of color who's a dermatologist, is to advocate wearing sunscreen. Sunscreen not only prevents hyperpigmentation from ensuing early on in our teens and 20s, but it prevents melanoma, acrolentigenous melanoma, which is the most common melanoma that we see. So yes, yes, you know, our genetics is something that we're born with, but we can modify the outcome of our skin health by using products that hydrate, and that also hyaluronic acid is important. As we get older, you know, collagen and elastin are denuded. So, you know, products with hyaluronic acid, a vitamin C, help again to ward off the aging process. So I'll talk about this again, you know, more in detail.
Thank you for that. For Mrs. Murray-Nyack, and Dr. Icy may back you up with some of this. What causes sudden cardiac arrest, particularly for those of us who have teenagers or young, you know, athletes in the family? What causes, if it's not necessarily a genetic problem that we don't know about?
So sudden cardiac arrest could be caused by a couple of factors. There could be underlying conditions. Dominic had an underlying condition. It was structural in nature. However, like I said, it was not picked up in the, you know, well child visits. You couldn't detect specific heart ailments with a stethoscope. That's just not something that you can do. So there could be something that's underlying, which is structural in nature, or what happened in the case of Damar Hamlin, which what we thought when we watched it, that it could be caused by something called commotio cordis, where you could be struck in the chest during, now you're more medical than me. I'm not medical at all. I'm not a doctor, but it's during the electrical, I guess, recharging, I'll just dumb it down to that, of the heart mechanism. During that state, during that recharging, if you're struck in the chest, it actually could cause your heart to stop. And nope, it actually stops your heart. Your heart will stop and you will collapse to sudden cardiac arrest. So it could be underlying in nature, or it could be a direct blow, an impact. And that is usually caused, it could be caused by lacrosse, a football, lacrosse ball, hockey puck. Even, you know, I get nervous when kids are playing and they're just like, you know, wrestling and swinging on each other, because a blow to the heart, a direct blow during that wrong moment, we'll just call it that wrong moment when the heart is recharging, it could stop your heart.
I think she did a great job explaining that. You know, it's the heart rhythm. You have an impulse or you have a signal to beat. And then the beat happens, and then the heart recovers and gets ready for the next beat. So if you get a blow or something that happens at that time when you're supposed to be recharging, then it could set off an irregular rapid beat that is not compatible with life. And so you have to interrupt that very quickly. Another blow can actually reset it, or, you know, CPR or shock.
All right, this next question is for Dr. Icy. When should one begin testing for heart health?
That's a great question, because as we learned, right, heart disease can happen at any time. And unfortunately for Dom, he was very, very young. That underlying congenital issue, coupled with, you know, what happened during exercising, caused it. But definitely, if you have a family history of it, you want to start early, because again, it can attack you at a very young ages. But if you know that there are any risk factors, if your blood pressure, your cholesterol, any of those are, you know, out of whack. Now we're seeing a lot of young individuals that there's an increase in weight. The foods that they're eating that are processed, et cetera, leads to early diabetes. That is becoming an epidemic here in the United States. And as you know, diabetes or elevated blood sugars is what we call a cardiac risk equivalent, meaning over years, it can end up in a heart attack. So I would say, number one, if you don't feel right, you go get checked out, but no age is too early. And if you have a family history of heart disease, you could start very early, even the 20s, 30s, going into the pediatrician or the doctor, getting checked out, getting an EKG, as Melinda says. And that's like usually the first line therapy along with the blood. And if there are any abnormalities, then jump on top of it.
So to add to that, for parents of athletes, the pre-screening for schools? Should they be doing EKGs on all athletes?
Yes. EKGs followed by an echo would also actually help identify if you need to do further testing. So it's recommended before every season, before your child actually starts participating in sports for that season, they should have a heart screening. Because it's critical to identify that, is my child's heart healthy to participate in sports? Is my child's heart healthy even to be, is to even be going like to school? When I say to school, they participate in gym, physical education. So when I say gym and when I say school, it's not, are they healthy enough to, go to class? We really want to make sure when they participate in gym, are they healthy? Screen their hearts. It's not a requirement in New York State, but give me time.
For Dr. Holder,
Yes.
how much is too much for skin peeling procedures or facials?
How much is too much? Well, I think, you want to go to someone who's an expert, who understands, your skin type and who has the experience with your skin type. My patients, I usually do, depending on how bad the condition is. I determine and I let them know initially how many peels they can tolerate, and then often they maintain with me, maybe once to twice a year, So it all is individualistic. But you want to go to an expert. There are people doing peels on type 4 through 6 who are causing scarring, because they just don't have the training or the knowledge to know what to do. Not only not what not to do, but if you do it, how do you reverse it? Because it can be reversed often if you get on top of it right away and do the right thing.
Thank you, Dr. Holder. This
Pleasure.
next question is for Melinda. Is sudden cardiac arrest and a heart attack the same?
Absolutely not. A sudden cardiac arrest, you think of it like apples and oranges. A sudden cardiac arrest a heart attack can lead to a sudden cardiac arrest, but they are two different things. Think of it like a heart attack is more of a plumbing problem. You think about clogged arteries, you think about when you're squeezing, when there's a squeeze on a hose or something and the blood cannot flow. That is a heart attack, basically. And someone can still be alert and they can tell you that they feel pressure on their chest, or they can actually still be, they're still responsive. They're talking to you. A sudden cardiac, so my first husband had a heart attack. My son had a sudden cardiac arrest where his heart abruptly stopped and his vital organs began to shut down. So you think about that as an electrical problem, because things that lead to a sudden cardiac arrest is more electrical in nature. So our plumbing, a clog, a sudden cardiac arrest, electrical, lights out. You're immediately unresponsive. You will still respond in the same nature of emergency. However, when someone has become unresponsive at that point, every minute that passes is a 10% less chance of their survival. So immediate CPR, compressions only, will help sustain that person until emergency responders arrive.
That's a great way to break it down. Thank you.
Any questions from the audience? I don't want to seem like we're dominating. Yes.
How do you check to see if the pulse is stopping? Like, how would you know if the pulse is-
Well, medical professionals, doctors would know where to check for a pulse. I'm a common lay person like yourself. I would not really waste that particular time looking for a pulse, because every minute that passes is a 10% less chance of survival. It would take me at least 5 minutes to find a pulse. That person would not survive. I would simply, if the person seems unresponsive, try to arouse them by just tapping them on both shoulders. Are you okay? Are you okay? If they do not respond, I'm naturally going to assume it's a cardiac arrest, and I'm going to immediately go into CPR mode.
Great.
I do want to say sometimes the people are out cold because they're drunk or they're high or something like that, right? So, you know, if you arrive upon the scene and you see someone down on the floor, don't assume that they're at sudden cardiac arrest. You would check for the pulse in that case. Let me just say though, when you're not having a pulse, your blood pressure is very low, right? Because the heart's generating the blood pressure and you could feel the pulses, and everybody can check their own pulse. But if you're able to check a pulse in the wrist, that means the blood pressure is at least 70. But most people will just put a finger on the neck, or when you go to the person, you're going to see if they're breathing, you know, if their chest is moving. So you're not going to immediately jump on top of someone. But if you see that there's no motion, no artifact, don't waste time. Start doing CPR, as Melinda talked about, because you can save their life. So you try to arouse them. Are you okay? Are you okay? Do they respond? Are they shaking? Even if they don't talk, if there's some motion or movement, they're alive. So you're not going to compress their chest while they're still alive. Yeah.
Follow up to that question, can it be dangerous than administering CPR to someone who doesn't need it?
Well, if you would first, and I just want to clarify, you want to see if they're alert, you're going to arouse, you're going to stimulate them. Basically, they're unresponsive. You're going to tap them firmly on both shoulders. You're going to be in their face. Are you okay? Are you okay? You're shaking them. You want to arouse them. There is also such a thing that you think that someone is breathing. They're actually not when they're in a sudden cardiac arrest state, because there's a thing called agonal breathing. And they could be snorting and gasping, and that's not normal breathing either. So your normal breathing is what you and I are doing. If they're doing agonal breathing, if they're not responsive, they're not making that eye contact, you would begin your CPR. If you push on their chest and they get to say, what the heck are you doing? Then you know they're good, you're gonna stop. But don't be fooled by the agonal, non-normal breathing, but you do have to shake them first. Are you okay? Are you okay? The normal person is gonna get up and say, oh, you know, even if they're like not in the state that you want them to be in, they're gonna say something to you.
Right. The agonal breathing, that's like basically you're already dead or just about dead. And it's like a reflex. So you won't have a pulse. It's like, you know, you're just, you know, it's not an effective breath that's going to give you air, oxygen. So you'll be able to tell they won't necessarily have a pulse. But to answer your question, if someone's heart's normally beating, it's, you know, they're sleeping, and then you compress their chest, there could be a couple of things. You can crack their ribs, or you could reset their heart and put their heart into an arrhythmia. Because remember, the wrong, you know, compression at the wrong time can set something off. So it's very important to recognize that they actually are, you know, in need of CPR before beginning to do the CPR.
And in a sudden cardiac arrest state, there are some symptoms when they're in that. They're going to be seizing. It may appear like seizure-like symptoms. They're going to be gasping, gurgling. These are some of the signs, and they will not be responding to you. And when you're in a sudden cardiac arrest state, you are clinically dead. You will not feel anything that's happening to you.
Any more questions from the audience?
I had a question about screening, skin screenings, because, you know, in this area, it can be difficult to find Black dermatologists. So I have seen a white dermatologist, and I said I wanted to just have a skin check. Seems like I'm at the time of my life where that is a good practice. And she was blonde and kind of looked at me and was like, yeah, you're fine. You know, like there was no screening. So, and it seemed like her impression was that Black people don't get skin cancer because of the melanin in their skin, which I don't, so I'm just wondering what your recommendations are as far as, is there a directory of Black dermatologists to check? And is that important to get those screenings?
People of color, type 4 through type 6, have a natural SPF of 14%. You know, you recommend usually, oh yeah, so I said that type 4 through 6, which is classified as Fitzpatrick, type 4 through 6 skin of color, we have natural, we have a natural SPF of 14%. But it's absolutely necessary, you know, as we age, to get that full body exam. I'm extremely thorough I mean, I check every orifice with my exams. And again, there is in terms of incidence of melanoma, I have on my slide that per 100,000 in the type 1 through 3, the Caucasian skin types, the incidence is something like 24% per 100,000. But in skin of color, there's a 1% incidence, which is significant. So screening is paramount. I would say, it's important to go to a dermatologist once you hit the 30th decade, for screening. And, there is a director of Black dermatologists, just so you know. Yeah.
Thank
Did I answer your question?
You did, thank you.
Thank you so much for the question.
This question is for Dr. Icy. What recommendation do you have regarding supplements for optimal health?
Oh, that's a hot topic, right? I'm sure everyone in the audience is on some type of supplement, right? Well, I'll tell you, you know what? There was just a new study from the American Heart Association at their meeting in this past November, and they looked at 4,000 individuals, and people spend, on average in the United States, $90 million a year on just supplements. And guess what? A lot of the supplements are actually ineffective, right? So just to give an extreme example, I had a patient who came in, she had spent $500 on supplements, but some of the supplements were against the other supplements. Like one was to keep you awake, the other one was to stimulate you. So if you take those two, what happens? So I would just say this. Number one, make sure you go to a reputable place to get your supplements. That's number one. Number two, if you are on medications, supplements can actually affect your medications. So when you go to the doctor or the healthcare provider and they say, what are you taking? They need to know what those supplements are. For instance, certain supplements can make your blood very thin. And for some people, that's good. But if you're on a blood thinner, you can bleed. So it's very, very important to recognize that. For instance, there's a muscle supplement to help build your muscle when you go into the gym, and it has something in it called creatinine phosphokinase. It builds your muscle. But guess what? When you go into the doctor's office and they do your blood test, something called your CPK is elevated, just like your heart enzyme. So you're like, why in the world is this person's CPK? And I had a true case like that. The person was taking creatinine phosphokinase. So you have to be very careful about what you're taking, bring it to your healthcare provider and let them know. And out of, let's say you have 100 different supplements, probably only 30 of them are effective. So some of them are garbage, and some of them are filled with fillers. So you have to, well, even if it's one particular supplement that you're taking, getting it from a different supplier may mean something completely different. So get it from a reputable place, do your research, bring it to your healthcare provider, and be assured that if you're taking any other medications, you basically find out whether it's interacting with your supplements. But I do take supplements, just do the research, okay?
So just piggybacking on that, Dr. Icy, if you were to recommend 3 supplements, what would be the 3 top supplements that you would recommend?
Oh, that's a loaded question. Well, it depends on what you're taking it for. What is it for blood sugar? Is it for blood pressure? Is it for cholesterol?
For your heart.
For your heart. Oh, that's a good one. Well, okay. So let's just put it this way. Omega-3 fish oil made by the right people could be effective for multiple things, but including heart health, especially in terms of lowering your cholesterol. So, there's actually prescribed omega-3, and then you can also pick that up from the store. Now, there's one that a lot of people take. Like people do a lot of things, let's say for their cholesterol, and I'm an expert in lipidology. So in this one study, they compared cinnamon, turmeric, ginger, and red yeast rice extract with the prescribed statin, which a lot of people are afraid of statin. So just another one out there, and I'm not prescribing this to you guys, but red yeast rice extract actually lowers your cholesterol by 7%. Not as effective as the statin, because that lowered by 35%, but that actually works. Another supplement that's good right now, but too much of it is bad, is vitamin D. But I would suggest get your vitamin D levels checked. They've done numerous studies, several cohort studies that show that vitamin D is important in terms of boosting your metabolism, but affecting, improving your blood pressure. So when you have a low vitamin D level, it can make you tired, it can reduce your metabolism, and it can affect your blood pressure. So you can, that's one that could be taken, but too much vitamin D causes kidney stones or calcium stones. So you just don't take certain things. You want to get your levels checked. So I would put those three out there. The others, people can talk to me offline to discuss those. Thank you.
Dr. Icy. This next question is for Dr. Holder. So Dr. Holder, for women taking estrogens, postmenopausal may impair the heart. Does the hormones in certain facial treatments have a systemic effect?
For women taking estrogen,
Yes.
does the hormone have a?
Does the hormones in certain of the facial treatments that you may prescribe, does it have any type of systemic effect? Is it only localized to the skin?
I have to think about that one.
Okay.
Oh, I'm sorry. So you're asking me if, just ask me one more time, please.
All right. So the question is, for women who are taking estrogen,
Yes.
postmenopausal women, does the hormones in certain facial treatments, does that have a systemic effect? Is it going to interfere with the estrogen that they're taking?
Do you have any, I'm actually working with a young dermatologist that has joined me, Dr. Palmer.
So I don't believe that any of the medications we commonly prescribe for topical creams have many hormones in them. So there are some things we use, like for melasma, we can prescribe metformin creams, which is actually something that's being studied now, but it's not absorbed enough systemically for it to have an interaction with any sort of systemic medication, either hormone replacement therapies that women are taking in the postmenopausal period, or sorry, menopausal period. I would say that I think the statistic they've given is like less than 5% or like 3%, especially if it's just a small area on the face that you're using these creams. And again, they're not usually known to have any interaction. So I think it's okay because we know that with these conditions that tend to arise during the hormonal changes like melasma, what else? Even the maturational dyschromia that Dr. Holder was describing, it's important that we apply the creams for them. And I would say, don't worry, you can apply them with safety because it's like less than 3% absorption.
Okay. And just as a follow-up, so I often see patients who want to be on estrogen replacement therapy because they say that it really helps their skin. Do you find that to be true?
Yes, because as we get older, as we age, estrogen, of course, is lowered. And in terms of just the hair anchoring into the scalp, estrogen can definitely help with, your hair getting stronger and having less tendency to fall out in alopecia, in terms of alopecia. So for sure, because we take care of skin, hair, and nails. So estrogen definitely will help in terms of hair loss, I believe, just based on science. Yes.
Dr. Rowe, how does RA affect the heart?
That's the first of the questions?
Yeah.
Okay. RA, for those in the room, rheumatoid arthritis you're talking about?
Yes.
So rheumatoid arthritis, lupus, or any of the inflammatory conditions, you have an elevation in certain hormones or certain conditions. So when your cells in your body senses an inflammation, it starts a process, okay? It's a reactive process. So you have your white cells called macrophages, and you have other cells that are called eosinophils, right? They like see stuff going on, they get nosy, they call their friends, everybody gets together, and you start an inflammatory reaction. So then your blood vessels become affected. They can become clogged off by all of this. And so what is supposed to be a protective mechanism can become a mechanism that creates a problem. So with this rise in inflammation, you start to have an increase in what's called your sympathetic nervous system. So you have things like epinephrine and cortisol, which make your blood pressure go up, which make your heart rate goes up, and you can have vasoconstriction, or the blood vessels close off. Everything works by oxygen getting to the organ. Even with the sudden cardiac death, when that arrhythmia happens, no oxygen is flowing. When a heart attack happens, no oxygen is flowing. So with the inflammatory process, we've now found out that this whole reaction that's meant to be protective can be counterproductive. And what ends up happening is what I just told you. And so there's a decrease in oxygen and the necessary nutrients. And so you have problems with your organs, such as your heart.
So if you're like on medication for RA to keep the flares down, that's going to help you not have a heart attack because you're keeping your flares.
So
at a
yeah, I
lower?
measure things like C-reactive protein, or CRP, and ESR, which is the sedimentation rate, and you follow that. Even in a heart attack, those numbers go up. When those numbers are high, there's something going on in your body that shouldn't be happening. So your doctor can track those numbers. And of course, based on that, you can get treatment, or you can know something's about to happen before it even happens. But let's say, for instance, you have rheumatoid arthritis or RA, as you're being treated, if those numbers are kept low, then it's more protective.
Okay. And then I have a question for Dr. Holder. So it seems to me like a lot of African American or women of Black and brown skin color have a lot of moles on their face. Like, do you do anything about the molds that,
Yes, it depends. Of course, when you come to me, I make a clinical diagnosis, and
Mic up.
sorry, we go over the features with our dermatoscope, which magnifies, the mole like 100 times. There are certain misnomenclatures where you have something called a DPNs that are not, they're not nevi. That's very prevalent based on the type 4 through 6, which is programmed by your genetics. I will talk about that in my talk. I do with laser take those off. So if I find a mole, it has features of cancer, I will do a biopsy. Yeah, if it's a nevus versus the DPN, I will do a biopsy and act from there, depending on what it comes back as.
Great, thank you
Yes.
both.
Thank you. Yes.
Have you had,
Hidradenitis?
yes.
Okay, yeah.
Have you had a lot of success treating that? Because I was told it's genetic, and clearly a lot of us in my family have it, but it's just like, I haven't been successful in treating it at all.
Again, it depends on the extent, I have treated it and I have had success treating it. If it's severe, you can treat it with Accutane. Accutane.
I've never been given anything. They just cut it out. Like every single time I go, I'm like, okay. And they're not doctors, obviously, of color. So I'm like,
Yeah.
okay, I have all these scars, but I'm still dealing with this constantly.
Yeah, so you need a thorough examine to see the extent of it, and treatment is based on the extent, and I have had success with treating it.
Okay, I'm gonna look you up. The second, I have one more question. The second question is kind of along the lines of what she was talking about in terms of the moles.
Yes.
So what they said, it was like a skin tag I had. They
Yeah.
removed it and it grew back.
The skin tag grew back.
It
Did it
grew
grow back
back.
as a skin tag or
Grew back
as a
the same-
keloid?
The same way it looks, the same way it's very itchy, same thing, the reason why I went and got it taken off. And they said, oh, it's benign, it's fine. And they took it out and then it slowly is coming right back.
It sounds like it might be a keloid.
It's not a keloid.
It's definitely
I
a
have
skin tag.
them. It's definitely that. It's very crusty, like ish, like it's not a keloid.
What did you say, Dr. Plummer?
Maybe make an appointment.
Yeah, I need an
Yeah,
appointment.
yeah,
Yeah.
Yeah, I mean, sounds unusual that it would come back as a skin tag. So I'd
Mhm.
probably rebiopsy it.
Okay.
Yeah.
Thank you.
And send it off to the dermatologist.
Sure, we have another question from the audience.
Question for Dr. Icy. You mentioned 30 minutes most days for exercise. Is walking, do you get enough your heart rate up enough? Is walking, qualify for that type of exercise? Or?
Yeah, so first of all, let me just say the patients in my practice who are 80 and 90 and they look fabulous, they're walkers, they walk. The American Heart Association recommends 30 minutes on most days of the week. My lovely colleagues over here, they have a walking program and I love it because that's what people should do. They should you just need to do the bare minimum, 30 minutes on most days. So it's, there's, moderate activity and there's vigorous activity. So, I mean, walking is very essential, but you can do things like raking leaves. You can push a stroller. You can clean your kitchen. You can go up and down stairs. You can park further away from the Walgreens or CVS and walk more in the parking lot. So you can do more walking. That's very helpful. But to lose weight, the American Heart Association actually recommends 50 to 60 minutes, okay, with a vigorous activity. So walking, just a moderate activity maintains. There's a whole study looking at steps because we talk about steps. And that came out of a lot of research. And I know we say 10,000 steps. Or 10,000 steps for a woman or a male or a tall person or a short person could be very different. My husband and I walk and he's getting 10,000 steps. I'm only getting a few steps because I'm very short. But, the studies actually show 4,000, at least 4,000 on most days, up to 10,000 is good. So just, stay active and that kind of, gets your good hormones going and sort of keeps your body, sort of in check. Helps to fight off, various diseases if you're fit. And the one thing too is exercise actually improves your mood, right? So if you're depressed or you have an emotional, type of condition, exercising can actually improve that.
Great. So our last question before we break out for our workshops, and that's for Mrs. Mary Nyack. Is an AED safe for anyone to use?
Yes. Hello? Did I lose my? Oh, okay. An AED, and I just want to point out what that stands for, which is automated external defibrillator, is safe for anyone to use. It will only shock you if it detects that you need a shock. It's a very smart device. All you have to do is turn it on and it walks you through the critical steps that you need to do through either verbal, and now they even have virtual prompts. So it's safe enough for anyone to use. One of a student that we actually trained when hands-only CPR, how to do compressions, actually ran to get an AED to help save someone's life. It did not shock that person because the person didn't detect that a shock was needed. So it's safe to use, but I do want to point out that once it is on, there's 2 times that you don't touch a victim when it's analyzing, because if you're fine, it's going to analyze you and it's going to think that a shock is not needed. And the other point is when it's time to shock, because at that point, when it's ready to shock the individual, you will be shocked. So there's other things with special circumstances, because that's a pretty loaded question, because it could be at any point when is it safe to use, but we'll talk about that more in the training, like the special circumstances with an AED. But anyone can handle it. You don't have to be a trained responder to help someone.
Thank you. Can we give a hand to all of our panelists, for Dr. Holder, for Mrs. Mary Nyack, and for Dr. Icy? Thank you so much. This is so informative.